Sume Nume AO from the National Collaborating Center for the Determinants of Health is going to speak to us and leave us with some tips and strategies, thinking again about how do we go about this very challenging work of integrating the social determinants of health into our program planning.
But I'm just going to try and highlight a few things which I've heard throughout the day, which I think are really important when we think about the social determinants of health and health equity. Before I start, just a little bit about the NCCDH. As Maureen mentioned at the start of the day, we are a sister NCC to Methods and Tools, and we're based in Antigonish, Nova Scotia. I actually have the pleasure of working in Toronto, and I have colleagues who also work across the country. So if you live and work in Ontario or in Toronto, send me an email. We should go for coffee sometime. If you're in Winnipeg, we have a colleague there, and also have a colleague who works out of Summerland, British Columbia. One of the things which came to mind for me was why I got into public health. I got into public health because of my commitment to equity and social justice. So I care about health, but in many ways I care about social justice and equity a lot more. So I think it's really important for us to talk about these issues. I'm reminded of the World Health Organization's report, which was released a few years ago. And the report started with social injustice is killing people on a grand scale. If you can have a more dramatic opening to a report, I'm not sure you can beat that one. So I'm always reminded of that. So I think we all don't need any convincing that the social determinants of health and health equity are important. I think what we need is trying to figure out how in our everyday work, in our work lives which are so busy and so challenging, how do we fit in equity? How do we make sure this remains on the agenda? So a few things I just want to highlight, which for me have come up throughout the day. I want to start, we started off by talking about evidence, and I think Maureen really made the case for going to the best available evidence, and also pointed to the fact that there are areas which are equally as important to consider. I think when we think about the social determinants of health and health equity, we know that there's an evidence base to support action. We know that the evidence base about what works is growing, but if we think about public health, it's probably thinner than a lot of places, so we are challenged there to figure out what works. As the field deepens, this has been pointed out already, we know that some interventions can actually increase inequalities, and there was a great paper published at the end of last year, which is a really nice short 4-pager, which has a couple of examples of the kinds of things which we do in public health, which actually do help increase inequalities, which are obviously dangerous. So when we think about making some strides, what do we need to keep in mind? I'm going to highlight 4 things. Some of them have already been mentioned. I just want to talk about the importance of community engagement, intersectoral action, communication, and leadership. And someone mentioned Sudbury just before I got up. So at the center, we're exploring the 10 promising practices which you mentioned, and really trying to dig into some of the evidence around that. So we just completed some work on intersectoral action, and we're doing work right now on leadership and community engagement. I'll start with intersectoral action. By definition, the social determinants of health lie outside the control of the health sector. So we're thinking about things like housing, education, poverty. So I think it's a bit of a no-brainer that if we have any hope of making any difference, then we have to look outside of ourselves and really work with some of our intersectoral partners. I think it's always interesting to go outside of public health and think about the really important work which has already been done. We know that there's some things which we as public health are really uniquely placed to bring to the table. Some of those things I think which are really important is we can leverage existing structures. We can provide resources, and those resources can be in the form of financial resources. They can be in the form of human resources. We can provide our public health expertise, which really no other sector besides us possesses. So we're the only ones who have epidemiologists in the way we do. So we can bring that to the table. We have public health nurses, we have health promoters, we have policy analysts. Those are all things which we can contribute to conversations without necessarily being the sector which has, with your face up there. But you can provide those things in a very public way, but also behind the scenes. I think we can also help bring some credibility to the issue and to help make the links between things like poverty and health. I think specifically about the work being done in Montreal, which has been going on for decades. About 10 years ago, Montreal released a health status report which really pointed at the relationship between between poverty and health. And I think that really helped to legitimize what a lot of community-based organizations had been saying and knew for years. But the fact that you had a medical doctor who was willing to risk his reputation and say, hey, this really matters, and as a public health department, we're going to actually do work on this, I think has really helped. It didn't help the department take over the issue, but it helped lend some credibility to work which is already underway. In the area of intersectoral action, we also know from a recent review which we completed last year that a lot of the interventions being implemented happen at the downstream. And by downstream, we're talking about things like education and behavior change, which some work shows are actually more likely to increase inequalities. We know that there's a need for a lot more work around more structural level change, which a lot of research shows will have a greater impact on improving health equity. And I'm seeing some smiles in the room, which is always promising. The other thing I want to say before I move on is, and we talked about this a little bit on my table, there's a lot of pilot level work which is going on across the province, and without a doubt, the more we're able to share those stories, document them, get them evaluated, researchers are always, I think, looking for community partners to work with. So just find a researcher who's really interested in your topic and get them to work with you. A lot of them will actually do it for free, and they have very eager graduate students. So that's intersectoral action. Moving on to community engagement, we know that the communities most affected by health disparities and who have least access to the social determinants of health are the communities with the least access to power. So often dealing with communities which are extremely marginalized and extremely disadvantaged, I think it's critically important to ensure that as we plan our programs, before we even think about planning our programs, the voices of those communities are centered in the discussion. So really having them front and center, which in many ways I think is very counterintuitive to the way we're all trained. We're all probably very highly educated, and we have been taught to know that what we learn is what is best. So I think part of that really requires is sometimes getting out of the way and letting community voices really to help inform the process. I don't think that means sort of dropping the research or anything like that, but I think it means listening to community concerns as really legitimate and valid and working with them to come up with solutions which are both acceptable, accessible, and also evidence-informed. I think we all do that in our daily work, both around the social determinants of health, but also in other areas. So across the country, we're using, I think about New Brunswick's poverty reduction strategy. And a really critical part of that process has been the use of community inclusion networks, which have been established across the province and are really helping to develop the action plans and also helping to implement them. Obviously, in the community engagement process, I think we have to be mindful that we're not just reaching the usual suspects, so not just the people who are easiest to get to. Part of that challenge, I think, means going to where communities actually are and not necessarily where we think they'll be. People who are marginalized communities, we obviously know don't access services as much as we would like them to. So I think really going to where the community is really our good strategy there. I think there are also interesting examples around using citizen juries and other things like that in community forums to help inform our actions as a sector. I'm going to now move and talk about communication. Let's start the conversation. It's a video which Sudbury and District Health Unit produced, I think maybe 2 years ago now. And it's really it's a short little clip. I know for communities who have adapted it, it cost me about $2,000 to adapt it using local data. And it was a really interesting way to help communicate to both your intersectoral partners and the communities about what the social determinants of health are. I know when I talk to people, one of my nightmare questions at a dinner party is, so what do you do? I tell them I'm a knowledge translation specialist and I work with the National Collaborating Center for Determinants of Health. By the time I get to that, they're like, okay, I'm moving on. So, so you do translation. Anyway, so I usually avoid saying social determinants of health when I'm in settings like that, because the fact is most people don't understand it. When you talk about poverty, people understand that. When you talk about income, people are like, oh, of course income affects if you can eat healthy or not, right? And these are my accountant and business friends, like they get it. Now, whether or not you think you can do something about it is another question, but at least you can use language which is more accessible to the communities you're working with. I'm thinking about a medical officer of health in Nova Scotia, and she found that when she was working with people in the justice system, she's talking about housing and poverty and education, and the director of police looks at her and says, oh, you're talking about the social determinants of crime, right? Because they are really the same social determinants, but you're just looking at a different kind of outcome. So I think really thinking about language which will resonate with your audience, that language may never make it into any of your official program plans, but if you're talking to a business person, right, they want to know what's the cost of poverty. And we know that in Canada, I think, 2011 report estimated that poverty costs the country about $25 billion a year, $25 billion. I had to check that twice because I thought it was a lie, but it's true. I think there are also interesting stats around how much it costs to, say, provide emergency shelters for people, about $42K in a city like Calgary, or how much it costs to send people to prison. It's about $120,000. That's like way more than how much I actually make. So the fact that you can give someone a decent paying job instead of sending them to prison and it costs way less. Affordable housing, I think, is estimated at $13,000 to $18,000. So really not that expensive to do. So there's some interesting work being done to present that information in really interesting ways. There've been videos being developed across the country, and I'm really excited because almost every other week, right, I get an email saying, oh, check out this cool video. So that really makes me pleased. The use of visuals, I think, is really very important. There's a lot of work being done right now using infographics. So infographics are really cool visual representations of data. So it's taking really large numbers and trying to depict them in really simple visual ways so that way people can actually see what you're saying. They're typically very colorful, but they help get the message across. And we try as much as possible at the center to help sort of collect some of that information and have available on our website. Social media is a big thing right now. For those of you on Twitter, we are on Twitter. I know some people are. Our handle is NCCDH _CCNDS, CCNDS, and we're on Twitter. So I think that forum really provides a really interesting way to meet with other people who are also interested in the social determinants of health and health equity. One of the things which we hear when we go across the country is a lot of people who care about equity feel very isolated, especially if you find yourself in an organization which is not necessarily supportive of the work you do. So I think they are really, like, social media is a way to help connect with people. At the center, we support an online community. It's available through our website. Our website is www.nccdh.ca, and to get directly to the community, it's the same URL of /community, or you can just go to the main site. And those really are really interesting ways to connect with people who care about issues, who really get the issues. So you're no longer trying to convince people that it's important, but you're actually now saying, we know it's important, what do we do? I was thrilled to have Saskatoon present because I think they really presented a really interesting story about how you start from trying to get the evidence and then walk through, not just saying there is a problem, but hey, we have 41 or 42 policy options, 46 policy options. So these are concrete things which we can actually do, and not everyone has to be involved in all 46. I've heard your MOH Curry speak a couple of times, and he says, well, some things some people will buy into, and so you work with those groups on those set of issues, and with other groups on other set of issues, and then you help to move the issue. The last thing I want to talk about is leadership. When we did our environmental scan in 2010, we heard from across the country that leadership is a critical issue. Leadership is an issue for two reasons, because sometimes it can help prevent action on the social determinants of health, but sometimes it can be really amazing and support action on the social determinants of health. If you think about the health unity here all the time, doing interesting work in this area and really doing innovative work and taking action, I think they all share a future. They have excellent, visible, credible leadership, right? One of our goals at the center is, as our scientific director, Connie Clement, often says, our goal is to try and get to a point where in 10 years, we no longer say Sudbury and District Health is doing good work. We no longer say Saskatoon is doing good work. We no longer name, Rosanna. I know Rosanna is somewhere in the room. I hear your name all the time. We no longer name Penny Sutcliffe. We no longer name Curry Newduff. Like, we get to the point where it's impossible to name who is doing work because everyone is doing work in this area because organizations are supportive. We recently hosted a conversation on our online community, and we asked people, what does effective leadership look like, and how do you build it? One of the things which we heard very strongly is that leaders for health equity share an incredible passion and commitment to social justice, that they take an explicitly structural view of the world. And by that I mean a really clear sense that health is not about what you eat and how much you exercise, but that really it's produced in the communities we live, work, and play. So obviously where we live influences what you eat and how often you can exercise. And also really they got it, they understood the social determinants of health and they understood health equity. One of the things we've talked about today is how difficult sometimes it is for us to let certain things go. So great leaders understand how to work with change and actually help motivate people to come along. And before I close, I just want to mention that I'm using leadership very broadly. And when I talk leadership, I'm not thinking about CEOs, directors, or MOHs. I'm thinking about all of you in the room. Because when I see leadership being exercised, it's being exercised by people with a variety of job titles and a variety of functions within their organization.